Good morning, dear colleagues. We would like to start our session. We are very grateful for organizing committee and especially for Zoran, who invite us, and we have the possibility to share our knowledge and experience. So we will introduce ourselves. So I am Professor Žana Bumbulienė from Vilnius University, and also I am WCPAG President, and today it is a big honor to be here, and maybe our panel, we will start from the classification. Just to remind you, what does it mean, primary amenorrhea? It's defined as failure to reach menarche, and evaluation should be undertaken if there is no pubertal development at 13 years of age without no pubertal development, if menorrhea not occur 3 years after telarche, and if is patient 15 years or older with normal secondary characteristic, but with the absence of menses. And there are 3 classifications of amenorrhea. The first one, the types of amenorrhea are classified by, based on functional compartments, and all other reproductive axes can be viewed as having 4 compartments. The first one, outflow tract, it means it can be Mullerian malformations, for example. The second one is ovaries, is gonadal dysgenesis as example, and very often pituitary and hypothalamus causes are grouped together, for example, functional hypothalamic amenorrhea, eating disorders. The other classification related to secondary sexual characteristics, it can be well and fully development in congenital malformation, non-developed or retarded in endocrine disorders, and with signs of virilization of ovarian or adrenal origin. And the third classification relates to hormonal state of the patient. It can be amenorrhea eugonadotropic, then we have normal level of LH-FSH. It can be hypergonadotropic, then the level of gonadotropins are high, and hypogonadotropic, then the level of gonadotropins are low. So now we start our panel, and we have our first speaker. Please. Don't forget to introduce.
Yeah, okay. Good morning, everybody. So my name is Hideasaka Kibara from Yokohama, Japan, and I am a gynecologist and president of Japan Society of Adolescentology. It is my honor to talk in this session, and special thanks to Zoran and the organizing committee. I have nothing to disclose, so today, I will talk about national survey in Japan on primary amenorrhea, and then talk to comprehensive health management of women with Turner syndrome, called TS women. The topic is complications throughout their life and treatment of hypogonadism, such as pubertal induction and acquisition of bone mass, and as a preconception care for future fertility and pregnancy. This is this slide and the report of the national survey. So, conducted by the Japan Society of OBGYN. In Japan, most of the patients with primary amenorrhea are diagnosed by pediatricians or gynecologists. Therefore, we conducted a nationwide survey in both departments for the first time. So, to Training Institute Japan Society of OBGYN and facilities to which counselors of the Japanese Society of Pediatric Endocrinology belong. So replies from 283 institutions, and we got over 1,000 patients first visited pediatrics or gynecology for non-menarche. So the cause of primary amenorrhea in Japan. So the cause of primary amenorrhea were detected in 462 patients, and among them, abnormal karyotype, including Turner syndrome, was the most common at 26%, and followed by Mullerian genesis, such as MLKH, at 15.8%. So, Turner syndrome is one of the most common chromosomal anomalies and represents an important cause of short stature and primary amenorrhea. It is caused by loss of part or all of an X chromosome. So here is our report. So comprehensive health management of women with Turner syndrome. Figure on the right shows the complications of Turner women from our reports. There are many cases of short stature diagnosed in childhood, and growth hormone treatment is performed at the pediatricians. So in adolescence, secondary sex characteristics such as the onset of menarche are lacking due to the ovarian dysfunction, and hormone replacement therapy is performed. After adulthood, reproductive problems, osteoporosis, endocrine or metabolic disorders eventually occur. Therefore, as shown in the table on the left, healthcare for Turner women be comprehensive, with a focus on gonadal dysfunction and the coverage of other complications. So this is our research patient characteristics. So we have 107 patients, and 96 had amenorrhea, almost two of them primary amenorrhea, and about 70% patients from transition from pediatricians. So sorry for busy slide. So this is the left side shows a checkup list in our institution based on the guidelines, and the right side shows its results. And blue shows indicate complications recognized from the first visit. So osteopenia and osteoporosis are often observed. And the orange one is those who found during checkups after visiting us. Endocrine or metabolic disorders tend to increase with age. We provided medical care in cooperation with relevant specialized departments when necessary. And next topic is hypogonadism. And let me focus on osteoporosis first. Scheme on the left side shows the representation of bone mass changed with age. Bone mass lifeline is represented in individuals who achieve the full genetic potential and in those who do not. So blue and red shows the who. And graph on the right side shows comparison of bone mineral density of women with Turner syndrome and healthy women in Japan from a multi-center study, including our institute. BMD were significantly lower in women with Turner syndrome than healthy women. And next is a pivotal induction. So by low-dose estrogen therapy. The table on the left is taken from UpToDate, and a protocol to start with low dose of estrogen via transdermal agent during adolescence and gradually increase to the dose and then add progestin when the other dose is reached. The graph on the right side shows the method recommended by the Japan's Pediatric Society, and it's basically on the same principles as the table on the left. So gradually increase the dose step by step every 6 to 12 months. Let me, to clarify the effects of low-dose estrogen therapy, we retrospectively examined the relationship between the starting age of the estrogen therapy and with uterine growth and bone mass acquisition. And shown on the left side, the age of initiation was separated by 18 years old, and comparison was made between early initiation, late initiation, and menstruating groups. As a result, it was found that uterine growth can be achieved regardless of the starting age, but early initiation is necessary for the acquisition of bone mass. The right slide shows the effect of estrogen therapy in a patient. Uterine growth and increased bone mass were observed with transdermal estrogen used for 6 months. So let me move to the next topic, future fertility and pregnancy. If the ovarian reserve is not exhausted, spontaneous pregnancy can be expected. But cryopreservation of oocyte or ovarian tissue could be considered during adolescence for the future. On the other hand, oocyte donation is an option when ovarian reserve is exhausted. And in such a case, induction of puberty is important to prepare for the future. So, final topic is pregnancy. We performed a survey to clarify the current situation of pregnancy on delivery in women in Japan. We mailed the questionnaire to 406 peritoneal facilities, inquiring whether each facility had experienced cases of pregnancy and delivery management in women with Turner syndrome between 2008 and 2018. So we obtained 20 cases from 16 facilities. This is a list of 20 cases. 13 of the 20 cases conceived due to oocyte donation. In addition, although menarche was observed, there were 3 cases in which oocyte donation was required for pregnancy in the end, suggesting the possibility that fertility preservation was indicated. Okay, next. Oh, I'm sorry. This slide, so 13 of 20 conceived by oocyte donation, and 3 had spontaneous cycles. Okay, and shown the pregnancy outcome of mode of delivery. Complications during pregnancy include hypertension and gestational diabetes. In terms of mode of delivery, the rate of cesarean section was high, and the cephalopelvic disproportion and maternal complications were the most common reason for this. It was suggested that management of complications before pregnancy is important. So, in conclusions, management of complications and estrogen therapy for pubertal induction and bone acquisition are mandatory for healthcare for women with Turner syndrome in adolescence. At the same time, from the perspective of preconception here, there are preparations for their future fertility, pregnancy, and childbirth. Thank you for your attention.
Thank you very much. Thank you very much. The question and answer session we will leave to at the end. Okay, so please the next presentation.
I think that's me. Yes, yes. Good morning, everybody. Thanks for the organizers for inviting me, for the audience to be here on a sunny day instead of enjoying Belgrade outside. I am Beatrice Khater. I'm a family physician at the American University of Beirut, and today I have two hats, the hat of the family physician, and I am also a member of the Arab Coalition for Adolescent Health and Medicine. So this is the American University of Beirut. If one day you come to Beirut, it is a very beautiful campus, and I invite you to visit it. I'll talk about a case. I'll drive you through a case of primary amenorrhea. I have no disclosure. And the case is a 16-year-old girl presenting to the clinic with amenorrhea. She has no menses yet. And as we heard about the definition of said before, this is a case of primary amenorrhea, no menses at the age of 16 years. Okay, so what do you want to do next? Next thing, I assure you, she is not pregnant. We did a beta HCG. It is negative. We did FSH, TSH, and prolactin, and they are normal. Ultrasound was done. The uterus was present, and there was no evidence of outflow obstruction. And we know that 15% of girls with primary amenorrhea will have an anatomic abnormality that can be identified either by ultrasound or a physical exam. Anyway, these patients would be having cyclic pelvic pain, okay? And on ultrasound, we would diagnose, clinically, we would diagnose unperforated hymen, septated uterus, etc. So she doesn't have any of these. So we have primary amenorrhea, normal hormonal levels. On ultrasound, she has a uterus. So in the diagram, we go in the arm of primary amenorrhea, normal hormones, and a present uterus. On physical exam, she has secondary sexual characteristics. She has a Tanner stage of 5, fully developed. So we know that if there is a lack of pubertal development, this would suggest estradiol deficiency, and this would be either a hypothalamic pituitary disorder, ovarian failure, or chromosomal abnormality. In our case, the girl is overweight. She has facial acne, mild hirsutism, normal thyroid on palpation, no acanthosis nigricans, and no dysmorphic features. So when we have signs of hyperandrogenism, in our case, the patient had acne and hirsutism, we take the hormones, we check for testosterone or DHEES. In case of virilization or severe hyperandrogenism, we think of PCOS, obviously, but we have also to rule out androgen-secreting tumors. I press here. So based on our findings so far, we have a few diagnoses. Think it is not Turner. The specialist is here. It is not an eating disorder. By history taking, we ruled out. So we're left with the 3 diagnoses: the PCOS, the Cushing syndrome, and the adrenal hyperplasia. Obviously, ultrasound and imaging of the pelvis would diagnose that. So in these cases, we have secondary sexual characteristics. We have a normal FSH and a uterus available, and we are in this part of the organigram, which is not easy to read. Anyway, I want to take half of my presentation to give you new therapies for PCOS. And PCOS, it is a very, very common diagnosis in our area of the world, in the Mediterranean area. I don't know how frequent it is in Japan or the US, but it is. So many studies and very recent studies have shown, for example, that the treatment of we use for diabetes, which is the glucagon-like peptide receptor, which is given by injection, has been used and has been tried in PCOS. And how does it act? Usually it acts, the physiology, how does it act? It boosts the glucose-dependent insulin release after a meal. And a clinical trial comparing it to other medication has showed reduced in free androgen, reduced body weight, and improved insulin sensitivity versus placebo in hyperandrogenic PCOS women. So maybe there is a place for that in the future. SGLT2 inhibitors, which are also used in diabetes, they work by inhibiting renal glucose absorption and increasing the glucose excretion in the urine. They have been compared versus metformin, which is one of the first treatments in PCOS, and they have showed in overweight and obese patients with PCOS to reduce body weight, which is one of the first things we tell when we ask them to have lifestyle modification. It decreased serum DHEAS and had less side effects than metformin. Another study where they used SGLT2 during 24 weeks, it reduced body weight, fasting sugar, and it also decreased serum testosterone, free androgens, and increased SHGB levels. So also a novel therapy. What about probiotics? In every conference now, for everything, probiotics are used. Probiotics are supplements, and they have been shown to have a beneficial effect on metabolic profile in PCOS patients. They have a significant decline in weight, body mass index, glucose, and serum insulin levels when compared to placebo. Studies have reported that probiotic consumption could improve hyperandrogenism and menstrual irregularities in women with PCOS. Clinically, this is the fact. Does it affect their fertility in the future? This has not been studied yet. Acupuncture as well. Randomized controlled trial over 17 patients only with overweight and obese with PCOS showed improved glucose tolerance and decreased adipose tissue androgens. Recent studies showed that acupuncture ameliorates anxiety, and that we know, depression that are present in PCOS via decreasing serum beta-endorphin and androgen. And last, which is an easy thing, is vitamin D and calcium. Vitamin D is now studied in everything, you know, during COVID, for cancer prevention. Okay, it was also studied for PCOS, and supplementation showed to improve menstrual regularities, hyperandrogenism, and follicle maturation in women who have PCOS. And there was a significant reduction in total testosterone and androgen levels when there was a supplementation with calcium at around 900 milligrams per day, which is almost like 2 cups of milk, so it's not a huge dose, and vitamin D of 3,000 units per day, which is, the tablet usually is 1,000. And then it was increased to 3,000. And this showed a significant reduction in total testosterone and androgen levels. So these are the novel therapies. PCOS is continuously studied, and because it is a common, it affects the quality of life of patients. So I keep you with these ideas, and I thank you, and I urge you to discover beautiful Belgrade.
Thank you, Beatrice. And the next speaker, Sandra, please.
Good morning. My name is Sandra Pekic. I'm an adult endocrinologist from Belgrade. I'm working at the Department of Neuroendocrinology at our clinic. And I will talk about hypogonotropic hypogonadism as a cause of primary amenorrhea. I will cover two main regions about congenital hypogonotropic hypogonadism and acquired form of the disease seen in patients with various cellular tumors, with traumatic brain injury and cranial radiotherapy. I will start with a case of female 17 years old with no signs of puberty and with primary amenorrhea. Hormonal analysis revealed hypogonotropic hypogonadism. Other pituitary hormone levels were normal. There were no response of gonadotrophins on stimulatory test, LHRH test. Her pituitary MRI scan was normal. There was osteopenia on DEXA, and other analyses were normal. She was replaced with sex steroid hormones. What is important for her diagnosis? We must ask the patient about sense of smell. She had anosmia. Also, the family history is very important for these diseases. Her father has also reduced sense of smell. It is called hyposmia, and he had delayed puberty. So the clinical diagnosis in our patient was hypogonotropic hypogonadism associated with anosmia, which is called Kalman syndrome. We prove it with also genetic analysis. This patient was a carrier of two missense variants of two genes which are implicated in Kalman syndrome. Kalman syndrome or congenital hypogonotropic hypogonadism is a rare genetic syndrome caused by GnRH deficiency. It affects 10 to 20% of our females with pubertal delay, and in these patients, puberty may be completely absent or incomplete. In some patients, it is associated with non-reproductive abnormalities, like in our patient, it was hyposmia or anosmia, but other abnormalities, non-reproductive systems can be present also. The main problem is in the migration of GnRH neurons. These neurons are very interesting cells which originate outside the brain, and together with olfactory neurons, they may migrate from the olfactory placode into the brain very early during gestation, between 6 and 10 weeks of gestation. They enter the brain and settle in the hypothalamus and form synapses with many other neurons. This process of migration and the homeostasis of GnRH neurons in the hypothalamus, their function, it is well controlled by numerous genes. There are listed some of them here. The genetic cause of CHH is very complex, and it's changed a lot in last decade. Now we know that there is up to 60 genes involved in less than 50% of patients with CHH. Some of these genes are listed here. These two genes found in our patients were recently discovered. New genetic techniques allowed it. In up to 15% of cases, more than one gene is implicated in the disorder. It is called oligogenicity. It is a characteristic of CHH patients. One gene is also important. I will focus briefly on it. It is FGF receptor 1 gene. This is a family with familial form of the disease. We ask always our patients about the family history. The mother and father, they had 8 children, and 6 of them had CHH. 1 is female, 2 patients had cleft palate also. And all these patients, affected patients, and their mother, which is unaffected, it is asymptomatic carrier, have the same mutation of FGF receptor 1 gene. But in mother, it was incomplete penetrance of this mutation. Various types of inheritance can be present in our patients, X-linked, autosomal dominant, or recessive, with full or incomplete penetrance, with variable expressivity, and oligogenetics, as I told. Reversibility is also possible in this genetic disorder. It is a very rare phenomenon, especially in females, but we can expect it in patients with less severe phenotype in such mutations of these genes, which are listed here. And it is proposed that therapy with sex steroids may induce the maturation of GnRH cells, and then we have the reversible form of CHH. The fertility is also possible in these patients despite small ovaries and a small number of antral follicles. Our patient desired pregnancy, and after numerous stimulations and embryo transfers, after 5 years, she got pregnant and she delivered a child, the girl without complications. Some non-reproductive abnormalities can be associated with CHH, on the first place anosmia and Kalman syndrome, but also renal genesis, hearing loss, cleft lip of palate. And there are many syndromic cases of CHH. They are rare, but we in tertiary departments of neuroendocrinology may see them. Some of them, the most prevalent was CHARGE syndrome with a defined genetic cause. This is the patient from our neurologic clinic. She was 32 years old when she was referred to adult endocrinologist because of no puberty and no menses. She had neurological and cognitive decline during childhood, and she had late abnormal dementia, and we diagnosed hypogonatropic hypogonadism. It was leukodystrophy 4H, no pulsatility, as you can see on the left side of the slide. Her pituitary gland was small, and she had the mutation which is characteristic for her disease. These are rare cases. Now I will conclude with the congenital form of the disease, and I will talk about acquired forms. In every patient with hypogonatropic hypogonadism, we must exclude some expansive process in the hypothalamic pituitary region. In these patients, they may have headache, visual field defects, any mass effect can be present. Also, not only hypogonatropic hypogonadism, but also complete hypopituitarism, all pituitary axis affected, also with hyperprolactinemia due to compression of the pituitary stalk and lack of dopamine. Patients may have also posterior pituitary defects, which is called insipid diabetes. In these patients, she had primary amenorrhea and was referred to endocrinologist. The diagnosis of the pituitary mass in the cellular supracellular region was established. You can see the differential diagnosis, which is very large for these patients, and we decided not to operate her after consultation with our neurosurgery clinic because she had no other symptoms of the presence of this mass. She is regularly followed up. Other situation is prolactinomas or other pituitary adenomas, which are very rare in children. In adulthood, we can see these patients more often, but less of 5% of these patients present before the age of 18. The functioning pituitary adenomas predominates, especially prolactinomas, and the people present with amenorrhea, primary, and the galactorrhea. We can see this hyperprolactinemia in this patient, and the microadenoma, less than 1 centimeter in the pituitary gland. They are very responsive to the therapy with dopamine agonists. But also, our young patients may develop macroadenomas, even giant adenomas, with diameter of the tumor more than 4 centimeters. They present with mass effect, with headache, visual field defects, galactorrhea, and primary amenorrhea in females. And in some cases, there are genetic causes of these diseases, and in some cases, they are very aggressive, and resistant to medical therapy must be operated. What is the mechanism of hypogonadism in hyperprolactinemia? The mechanism is hypothalamic, the depression of KIS1 neuron in the hypothalamus, and then the suppression of the whole axis. I will talk now about traumatic brain injury as a cause of primary amenorrhea, as a cause of hypopituitarism. Always we ask our patients about brain damage during the birth or during the childhood. We ask about the bleeding during the delivery, intracranial and other bleedings, about birth asphyxia, about brain injury during the childhood due to falls, due to car accidents, due to sports-related injuries, which is increased nowadays with child abuse. And this is our patient from Novi Sad, a female which presented to adult endocrinologist at the age of 26, but we learned from our pediatrician colleagues that she started her neuroendocrine dysfunction at age 7 with diabetes insipidus. And her hypopituitarism evolved with time. So these patients must be regularly followed lifelong. Finally, at the age of 26, she performed a magnetic resonance, and there was an empty cella, no pituitary gland and no pituitary stalk. And when we asked the patients what happened just before the insipid diabetes at the age of 7, her parents recalled that she had traumatic brain injury. It was a mild head trauma, but just preceded her diabetes insipidus. There are little data about this problem in children, but we know from the study of adulthood that neuroendocrine dysfunction may occur even after mild traumatic brain injury. It can be temporary, reversible, or permanent, lifelong. It may evolve during the time. Pituitary dysfunctions may be isolated, and the most vulnerable axes are somatotrophic and gonadotrophic axes, and the deficiencies may be also multiple. And finally, I will talk a little bit about cranial radiotherapy, because nowadays we have a lot of patients who survived their cancers in the childhood. The treatments are better, the chemotherapy, the cranial radiation are better, and these children become young people and they come to our clinic. They survive their brain tumors, medulloblastomas, craniopharyngiomas, or germinomas. They survive acute lymphoblastic leukemia. And the part of their treatment was cranial radiotherapy. Half of these young people have at least one chronic disease, and there is no system which cannot be affected. One of the systems is the hypothalamus-pituitary axis and the hypopituitarism, and we can see other problems of these patients. It is important to know that the cranial radiation of the cellular and supracellular tumors of the hypothalamic pituitary axis may cause the damage, but also the radiation of the distant tumors, distant from this axis, can also cause the neuroendocrine dysfunctions years and decades after the cranial radiotherapy. And also, similar to traumatic brain injury, the most vulnerable axis is somatotrophic axis. These children do not grow. And the second axis is our gonadotrophic axis, and there is no puberty, no menses in girls. So the hypopituitarism developed years and decades after cranial radiotherapy, and it is dose-dependent and irreversible process. There are many damages in their hypothalamuses, and nowadays we have new stereotactic techniques of radiotherapy which may be introduced to these patients, like gamma knife, like cyber knife, proton beam, and these techniques are more precise and they spare hypothalamus. In conclusion, I presented some data about congenital forms of hypogonadotropic hypogonadism and these acquired forms, and we will discuss later on about what you're interested for. Thank you.
So, dear colleagues, I would like to continue my presentation. As you understand, the amenorrhea is a huge topic, and really to diagnose and to manage this pathology is quite difficult, and it is high level of medicine, I think. And then we divided our topics, what we are going to speak about. We decided that it is impossible to rule out functional hypothalamic amenorrhea, even it is more the problem of secondary amenorrhea. So, why? Because if we see what is the prevalence of functional hypothalamic amenorrhea, so in the cases of secondary amenorrhea, it's always more than 50%. That's why I would like to remind you maybe some basic things about functional hypothalamic amenorrhea, which is a non-organic and reversible disorder characterized by the absence of menstruation, may be related to various stresses. And it is ultimately the diagnosis of exclusion. And the main causal factors, first of all, it is stress, but can be metabolic stress, weight loss, severe dieting, eating disorders. It can be physical stress, exercise-related, heavy training, but also psychological stress after intensive emotional event. And it is a functional blockade of the reproductive function. So there is no systemic disease, no other illness. And amenorrhea occurs only there is a relative caloric deficiency due to inadequate nutritional intake for the amount of energy expended. So energy availability is equal to nutrition minus energy expenditure. And in the adolescent, the energy expenditure, it is not only due to training or rest, but also it's due to growth of our patient. So the functional hypothalamic amenorrhea is characterized by suppression of generates pulsatility, the overactivity of hypothalamic pituitary adrenal axis, disturbances of the hypothalamic pituitary thyroid axis, and of course energy deficiency and hyperestrogenemia. Of course, it is impossible to go to the details of hypothalamic pituitary gonadal axis regulation because it needs regulation from the central system as kisspeptin, also from peripheral as ghrelin, leptin, and also cortisol. But here in the scheme, you see the light blue boxes. It is the functional hypothalamic amenorrhea predisposing genes. And maybe I would like to stress something new, that new evidence support a common genetic basis of functional hypothalamic amenorrhea with anorexia nervosa, delayed puberty, and idiopathic hypogonadotropic hypogonadism. Why we have such question? First of all, because the stress events and the dieting is in most of our adolescents. Why of them respond with amenorrhea and other known? So this new data suggests that it is the hypothesis that monoallelic mutation in genes that modulate hypothalamic pituitary gonadal axis may lead to anorexia nervosa, delayed puberty, or functional hypothalamic amenorrhea, while biallelic mutation could lead to more severe phenotypes such as idiopathic hypogonadotropic hypogonadism or even Kalman syndrome. So our evaluation is, as always, we start from good anamnestic investigation, which is very important, and then we measure height-weighted calculate body mass index. So we perform physical examination in order to exclude any other organic, systemic, or endocrine diseases. We perform laboratory tests, hormonal tests, pelvic ultrasound, and DEXA. DEXA is very important because at that time we need to assess the peak bone mass. And if we don't, at that time you have hypoestrogenemia, so we never access this peak bone mass. And we, after 6 months of amenorrhea, we need to measure DEXA. And here you see the typical hormonal patterns. So in most of cases, we see normal FSH, but low LH. And as you see, other hormones. And also in most of cases, of course, we see very low estrogen. And of course, there is anovulation and no progesterone. So management. The most effective is multidisciplinary team, and it must consist from primary care physician, nutritionist, gynecologist, psychotherapist, which is very important for adolescents, and of course family members. And management often requires behavioral changes, and it is very difficult for adolescents. Such adolescents are perfectionists. They learn a lot, they know from internet a lot, and they want to be the perfect in all her life, so it is the best student in the school. And we really need to negotiate with such patients about their behavioral changes, and it is really very difficult. And options for treating the functional blockade of reproductive symptoms, first of all, increase caloric consumption, to improve nutrition, to decrease exercise activity, and because we require weight gain. And treatment. If we speak about medical treatment, a short use of transdermal estradiol therapy with cyclic oral progestin in adolescents should be started only half or even year after ineffective nutritional, psychological, or exercise lifestyle modulation. So in this case, work the whole team, not gynecologist only, but we need nutritionists as well. We need psychologists in order to change their mind. And the use of the hormonal replacement therapy has an effective effect on bone protection and reduction of risk of fractures, but also positive effect of cognitive function, obsessive pursuit of a slim figure, and reduction of anxiety and dissatisfaction of one's appearance. So my message is that we should educate our young patients regarding the influence of excessive exercise, of stress and weight loss on their menstrual cycles, and the risk with associated bone loss. And multidisciplinary treatment approach is necessary, including medical, dietary, and mental health support. And the most successful strategy is weight gain, exercise reduction, and psychological support. And maybe at the end, I would like to advertise the next Congress of Pediatric Adolescent Gynecology. Is organized by WCPAG. It will be the next year in Thessaloniki. Very nice time in June, and very nice city. And we want to invite all of you to take part in our WCPAG Congress. And also, I want to tell you that now we have the book written by well-known gynecologists Metella Dei and Vincentina Bruni. It is must-have book for all gynecologists, pediatricians, other specialists who are involved in the field of pediatric and adolescent gynecology. And you can find leaflets how to buy this book because you need to contact WCPAG, and we will send you the book. And now we have enough time to discuss and to speak about the amenorrhea. So please start our discussion. So maybe you would like to ask, first of all, questions or comments from the auditorium, because as you know, amenorrhea is really a huge topic, and maybe you want to discuss your cases, so please.
I have a question for you.
Yeah.
I deal with anorexic girls, and you mentioned in the treatment that you would give estrogen transdermal. Is there a reason why not oral, for example?
Because then we speak about patient, young patient, and it is always we want to protect her liver, yeah, and maybe because it also not always she want to take pills.
Yes.
Sometimes, I don't know why for adolescents it's easier to use the spray or the gel or something else than take a medication. In their mind is something different, you know.
Yeah.
If you use external, it's nothing. If you use internal, maybe it will be problems with gastrointestinal and so on. So sometimes it's psychological as well.
Okay, okay. Now, to confirm that, I had a patient with anorexia. I wanted to give her vitamin D. She said, how many calories are there in the... I said, I don't know. Okay, so maybe tablet means calories, weight gain in their mind as well.
That's why I think. Yes, please.
Hello, I'm Anna from Slovenia. I would like to ask if it is possible to have functional amenorrhea when there is a normal body mass index.
Yes, it is possible. And if it was, because we speak not about weight only, we speak about stress. So after emotional stress, for example, even exams, some of students in the disappear menstruation. That's why it's possible. And there is a question.
I want to ask a question about FHA. You said the short-term circle HRT. I want to know the period of treatment of circle HRT.
So, sorry,
So how long time for the circle HRT for FHA?
How long to use hormonal replacement therapy you want to ask? So it is very individual. So we cannot tell, because in some cases, you know, the menses not come back, not after half a year, not after 1 year. And I really have patients after 10 years and without menstruation. Previous healthy girls, but after severe dieting, it was impossible to restore the menstruation. So in this case, it will be long treatment. But in some cases that we have normal, after sometimes normal weight, so she is understanding what happens, behavioral changes, and in addition of hormonal replacement therapy, I think that it is around 1 year. It's not so short, but yeah. It is my experience. Maybe you have other experience. It is, please, if you want to add, because, you know.
I think it depends on the duration of the amenorrhea. So it's if it's long, I think it's heavy. Yeah.
How can we to judge we should stop?
How to stop?
When to decide to stop?
It's also individual, but if you see that weight is normal, that with the training normal, and everything as you feel, that now you can stop, so you can do this,
Right.
and to try break for example, for 3 months, and then to see it happens menstruation or no, to see in the ultrasound, do you see something that, what about endometrium? Okay, how works? Maybe you will see the larger follicles in. So it depends. Then after 3 months, you can wait a little bit or to continue or to start from the beginning. So it's you know, in amenorrhea, it always, especially if you speak about functional amenorrhea, you never know that it starts, you know, to work. Sometimes it is very difficult cases, but very nice outcome. And sometimes you cannot understand why. Everything is okay, weight is okay, this exercise is okay, and no menstruation. As I see, the functional hypothalamic amenorrhea is very important.
I'm Lydia from Croatia. I would comment colleague from Slovenia. I also have patients with normal weight, but also physiological, functional amenorrhea, because they are sometimes bulimic patients, even sometimes overweight. But stress is for sure, and for sure, when you said all multifunctional approach, for sure, family is whole family should be in progress. But I raised my hand because I wanted to comment the number what a colleague from Lebanon said. They have plenty polycystic and who knows how much around. I would only point out the point that sometimes it's overdiagnosed, not in your country, but we should all be aware of the fact that ultrasound appearance of the polycystic ovary is physiological until age of 18. Sometimes I don't see somebody stress out this fact. So the ultrasound image of a polycystic ovary is not a point of diagnosis in this age. And sometimes I see plenty from other colleagues, they said they are morphological polycystic, they give diagnosis. Even sometimes hormones could be more or less disrupted. Yeah. Okay. That would be about all.
Yeah, thank you for your comment. As a matter of fact, we in the Mediterranean area, people are have more hirsutism, which is genetic predisposition. So usually they say, oh, you have hair, you have polycystic ovaries. Also, it is wrong. So we have to be cautious about these things, and thank you for your comment.
Yes, and as you know that according to the guidelines from 2018, yes, we cannot diagnose polycystic ovary syndrome 8 years after menarche due to ultrasound appearance only. Yeah.
Sure.
Yeah.
Hello.
Yes, it is.
Yes, it is
It's
working.
working.
Yeah.
Sorry. So I have such questions. For example, I also have such patients. They are stressed, anorexic or bulimic. But when to start this treatment? I already diagnosed. Wait 6 months, 1 year, and after starting hormonal replacement therapy, or after 3 months, for example, if I see there is little progression, for example.
I think that it depends on her progression. Yes. So how is with her weight? How is with the stress is something, and how is the training? And as we told, so we need to try to treat, you know, for her to understand and to change her behavior. Yes. If we see really progress, so, you know, maybe we do not need even after 6 months the hormonal replacement therapy. Maybe everything will be okay without therapy. So it's the
I
best.
have such case because 1 year ago we started the same. She has she was anorexic. her mother agreed that she has, and another medical therapist also was involved. Now her hormonal levels becomes FSH, LH increase because it was like 0.
Yeah.
And after September, she has normal weight gain, but in February, she has no menstruation till now. And it was emotional again for her, and now we gave her hormonal replacement therapy because it was emotional. I have normal weight, I have everything, I'm making everything, but again, no menstruation. But hormones increased, like as
So
she
maybe
changed.
we need to look also for other causes of
Yes.
maybe also polycystic ovary or something like that, you know.
Just ruled
So
out.
we need to exclude all, as
Yes,
it is
exclude.
diagnosis of exclusion.
Yes,
And
yes,
sometimes after some months we see something else, you know. So,
Yes,
so
no,
that's why.
ruled
And
out.
there is a comment on the weight. It's not only that she gained weight, she should go back to her normal sex weight, the weight she should have genetically and because of
Yes,
her.
yes,
Okay.
but it was emotional. Second time, it's emotional condition. Thank you.
Okay, so our time is over. I want to thank all of you for participating in our panel. And first of all, I want to thank my colleagues, Beatrice, Sandra. It is very difficult, you know? Here for participating here, and see you during the next panel. Thank you.
Thank you.
Thank you.
Thank you.